On to the next talk, that is by Professor Amit Gupta about the correction of management of myopia, and I think essentially he'll be speaking about the surgical correction of myopia. And after that, if time permitting, we can take any questions related to any of the talks.
Well, thank you, Dr. Suresh and GMC for calling me for this very interesting session. And then I'll start with a little statistics. This statistic is good news for the refractive surgeon and bad news for the retinal surgeon. And this is that the number of myopes are increasing. And if we look at, it's going to just become a huge epidemic. And we are somewhere here. And if you look at the percentage of people who are low myopes, their prevalence is going to double by 2050. And if you're looking at high myopia, almost 10% of the world's population is going to be high myope. High myope means more than -5 diopters they have defined in this. So we are looking at a significant problem. As far as the refractive surgeon is concerned, we have to offer solutions to these patients, what to do when you're wearing spectacles. And so if we broadly divide things, if you look at the power of the eye, the cornea and the lens, they form the major component. So we can alter the cornea or we can alter the lens, and therefore we can get rid of the spectacle power of the patient. So these techniques may be incisional, which are non-laser incisional, or they may be other, excimer laser based incision techniques. They may be lens based, where we play around with the lens, or they may be a surface ablation. So if we look at it in further details, we look at radial keratotomy, astigmatic keratotomy. This is like, we don't do this anymore, mainly historical. This is something which is really in vogue, which is like the SMILE procedure or the femtoLASIK. And we can look at the phakic IOLs, clear lens extraction, or even multifocal accommodative IOLs and all stuff. If you look at surface ablation, we look at the PRK, the epi-LASIK, LASIK. So I'll just give you a rough overview so that you have an idea of what goes on in these procedures. So look at the PRK means that we are just changing the anterior surface of the cornea. We are not giving a cut in the corneal surface. And if you look at LASIK, it involves cutting the stroma and then we ablate the cornea using an excimer laser. In case of SMILE, the excimer laser is not used. It's a single machine procedure, and we just remove a piece of cornea which is shaped to best remove the refractive error of the patient. Now, so this is, I've already gone through these terminologies, and the basic thing is that we have to remove the epithelium. Usually it is done using diluted alcohol, and once this is removed, the surface is ready for the excimer laser ablation. So for a beginning refractive surgeon, there cannot be any procedure which is safer than this. So this is 20% alcohol applied for 40 seconds, 30 to 40 seconds depending on surgeon preference. Avoid a spillover. So this reduces the red eye and discomfort in the patient. And very gently remove the epithelium. Try not to damage the structures by doing a very rough dissection. Because the excimer laser will carry on in that roughness only as it ablates. So once you have a very nice and smooth surface of the cornea, you can go ahead and dry it, and this is followed by the excimer laser. So these red spots, actually it's invisible, but red spots are just to indicate where the laser is falling on the eye. Immediately cool the cornea using chilled BSS. Very important step. It decreases the keratocyte activation, decreases the amount of scarring in these patients. Mitomycin C. So this is applied. Again, make a little droplet on the cornea so it doesn't spill over. It doesn't have effects on other parts of cornea where you don't want it to touch. And give a nice thorough wash at the end. So this is the end of the procedure. And so there are various ways of how to remove the epithelium. So I've shown you alcohol, which is like the very cheap, and this is something which is more fancy. This is known as the epi-LASIK or epipolis LASIK. So it's just like a bulldozer moving some sand. So it just is a plastic kind of a keratome. It just puts the epithelium away, and it actually comes off like a flap. And many people at the end of the procedure, they will either replace the flap back, or what I usually do is just amputate this flap. So the rest of the procedure remains the same in these patients. With many machines now, it is also seen as the trans-epithelial, examination, PRK. So in what happens, you see these blue reflexes. This means that the epithelium is there. So it usually ablates around 50 microns to take care of the epithelium, and then goes on to the usual photorefractive keratectomy procedures. So many machines are built for this, like for the Schwinn or some other machine, they have this mode, transepithelial PRK. Okay, so you don't have to remove with alcohol, just feed that mode, make the patient lie down, and it goes from first the epithelium is removed, and then the number is removed. So upside, what is the upside? It's simple, it is reduced surgical curve, and surgeon friendly, cheaper. But remember the downside, that there is a moderate discomfort in the patient. There may be a risk of haze or scarring, irregular astigmatism, over or under response, infection because epithelial defect takes time to heal, increased time to the best uncorrected vision. It may take weeks. The patient has to put medication for at least 1.5 to 2 months in this case. Key points, that it does ablate the Bowman's layer. We don't really fully understand the consequences of the removal of the Bowman's layer, but it is very useful in patients who have thin, weak cornea. So many situations we have discussed on a pentacam. We might just offer them surface ablation rather than this. Post-operative pain and stromal haze. For 1 day, I like to give topical ketorolac. It gives a considerable relief to these patients. Chilled BSS and intraoperative use of mitomycin are critical to prevent the haze from happening, especially at higher degrees of myopia. I usually do up to -6 diopters, but some people in India are going higher with the photorefractive keratectomy, and especially useful in patients with epithelial basement membrane dystrophies or some kind of epithelial problems. You just it is maybe the procedure of choice in these patients, not LASIK. So if you look at LASIK, as I said, stromal flap, and this is followed by the exam laser ablation. So the tradition was the cold cut, in which the blade was put into a keratome and then the cut was made. And then this was followed by sub-Bowman keratolysis. So sub-Bowman keratolysis had certain advantages that I will come to, but this is again, these are all incisional LASIK procedures. But we moved on to something known as a bladeless LASIK, which is cut was made using a femtosecond laser. And one of the reasons was that if you see, this is the, with the keratome, there used to be a meniscus flap. You should remember it. Meniscus flap means as the cut was happening peripheral, like a donut, the periphery was thick, center was thin. So this led to certain problems. And these flaps, we had to look at the patient's keratometry. A patient with 42 diopter cornea, we would have a particular selection. With 47, we would have a particular selection. So there were a lot of variabilities which came while making the flaps. And while with the femto-LASIK, the epithelial thickness was more accurate. It was just planar, and also varied geometry, varied thickness of the flaps could be very precisely planned out. And this is why we moved on to, femtosecond laser LASIK. Any of the residents know the differences between the femto and excimer laser? When we talk about lasers at your stage, sometimes there's a confusion. What is excimer? What is femto? Gunjan? Anybody? Anyway, so just these are two totally different lasers. Okay, this is a near UV laser, which is 193 nanometer, and this is 1053. This is near infrared laser. So this works almost like an ND-YAG laser. Okay, you've seen the bombs which go off into the eye with an ND-YAG laser. So this is called photoablation. This is called photodisruption. So they're totally two different processes. And if you look at this, the focusing, this is a collimated beam, and this is a focus beam at any desired depth. Suction is not required for excimer laser, it is required for femtosecond laser. And if you see the tissue clarity, it ablates the scar tissue differently, whereas the femtosecond laser is unaffected by haze actually. Okay, and if you look at the penetration, it is absorbed by the first tissue. So you cannot go under the surface and do examer, but you can certainly go under the tissue and do the femtosecond laser. That's the beauty of femtosecond laser. So this explains there's a little spot and it expands like a cavitation bubble, and that once they join, they form the interface. Whereas if you look at the photoablation, what happens is, if suppose this is the tissue and there's a binding energy of 3.5 for example, and we fire, so there's an absorption of high energy UV photon. That is what the examer laser is all about. So this is of a higher energy than the binding force. So what happens is it forms a plume. The tissue actually almost kind of vaporizes. So there is a breaking of the bonds, and there is a promotion to repulsive excited states, dissociation, and ejection of fragments. There is no necrosis. So that is what the principle of a excimer laser is. So there are different kinds of platforms, wavefront optimized, customized, and topo guided. And I'm not going to details, but roughly what happens is that this is the most commonly practiced. What happens is, because the cornea is curved, in the center we are going to, the energy becomes more of the laser. As it goes to the periphery, the effect is less. So in case of topography wavefront optimized, that peripheral curvature, peripheral additional distance the laser beam has to travel is compensated. Okay, and wavefront customized is based on the average wavefront data of the eye. Then the exam laser ablation is done. Topo guided ablation is it first addresses the topographic abnormalities and then goes on to remove the refractive error. Okay, so that's more suitable for maybe some irregularity in the cornea. So again, downside is it requires a more skilled surgeon, more chances of intraoperative complications, flap complication, cost of equipment is high, and the upside is that it induces less pain, visual recovery is fast, and we can treat higher myopia, and there is no risk of subepithelial haze. And so, for example, if you see these photographs, these are flap-related problems. These problems like epithelial growth and striae, they have happened because the flap was made, and that is a part and parcel of when we do laser surgery. So the first step in any kind of femtosurgery is docking, is putting a plastic suction ring on the eye. And different machines have different designs of what is called the treatment packs or cones. And once that is there, the cornea is appugnated. So in this case, this is the IFS, this is a machine by J&J, and so this is the femto cut being made. And again, so this is a similar procedure. Now that the cut is made, we simply separate the cut, and we are lifting the flap using some special instruments. And this surface, instead of the surface ablation, now this is the stroma. So the advantage is you are preserving some of the nerves in a better way maybe, and also that there is no risk of scarring, you are not destroying the bone membrane. So these advantages I just skip. And yeah, it's opposite. So just two things to remember when it comes to femtosecond lasers is that if you look at the cutting process, it depends on both on the energy and also the frequency. So if you want a smoother surface cut, this is a rough surface, you need a spot of very high frequency, okay, which is at low energy. Only then you will have a smooth interface. So, and this is the reason why we have moved on to something known as SMILE. So if you look at the SMILE process, only because that laser is a much superior laser to what we are using for a femto laser. So what happens is basically you have to fashion out a lenticule, and then we just extract the lenticule out. And this is shaped in a way, just as the excimer laser shapes the cornea, it's going to reshape it, and we are going to just extract this piece of cornea after dissecting it. So there are a lot of other nuances and tips and tricks to it which I will not go into, but this is the basic principle of how this is just to give you an idea of the procedure. So there are three cuts mainly. There is a lenticular cut which happened, and side cut and the cap cut, and this is then dissected out. So these are some dissectors which are available, and then it's just the corneal stroma it comes out shaped in a way so that it gives a refractive correction to the patient. So of course there are studies which have compared the safety of this procedure and outcomes, and they have found it almost comparable to surface ablation, because you are actually leaving most of the cornea. So this is what people say like a keyhole refractive surgery. So I will skip the rest of it, and there have been a lot of studies trying to compare which procedure is the best procedure for our patients, and this is a huge study, a meta-analysis published in the AGO, and kind of again it showed that the choice of procedure is they give equally good visual outcomes, but perhaps the femtosecond laser LASIK is scoring over other procedures right now in most of the circumstances. This I'm going to skip. Well, thank you. Any questions if we have time?
Thank you, Dr. Amit. I think the chairperson of the next session, they already arrived.